Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Welcome to NRAS 2003. So I'm Dr. Mohd Sany from Hospital Ampang. I would like to continue with the second lecture for these basic high value blocks. The topic will be Axillary Brachial Plexus Block. I believe this is the commonest block which is quite popular among the beginners of for regional anesthesia. So I'm from Hospital Ampang. Basically, it is 700 bedded hospital and tertiary center for hematology and also gynae oncology. Okay, we are running roughly around 60 to 70 blocks per month, which now with the presence of Dr. Khairul, our regional anesthetist, we expected to increase the volume of cases on an annual basis. Okay, basically just to recap what Dr. Sabri have alluded earlier. Okay, so basically brachial plexus form from anterior primary rami of C5 down to T1. So basically we are blocking at several levels. You can do at the root, trunks, division, cords and terminal nerves. So basically these form roots C5 and C6 unite to form superior and C7 middle and also inferior trunk respectively. And these three trunks divided into anterior and posterior division, and they rearrange themselves into lateral, posterior, and also medial cords with relation to second part of the artery and becoming terminal nerves. So basically, once you talk about axillary block, basically you are blocking at the level of these terminal nerves. So just a quick revision for cutaneous sensory distributions. So basically, brachial plexus, the blocks, with a successful block, you will have blocking from the area distals from elbow, posteriorly distal to elbow. So so basically, this is area. So the lateral part of to innervate the lateral part of arm, and then the lateral part of forearm is a continuation of musculocutaneous nerve, and then lateral 3.5 cutaneous innervated by the median nerve and 1.5 by ulnar nerve, and also the medial cord innervates the medial aspect of forearm, and also the upper part, the medial part of arm innervated by intercostal brachial nerve, which comes from T2, and also medial cutaneous of arm, which comes from medial cord. And this is the posterior part. So basically, this is our team from Nizora. So basically, describe the various type of distributions of median, ulnar, okay, and also radial nerve. It correspond to axillary artery in the axillary space, and 67% of population have this kind of distribution. But somehow you will notice the numerous axillary veins surrounding the axillary artery. Okay, there are a few structures which you need to identify, which is compulsory to identify before you are performing the brachial axillary brachial plexus block. Okay, so it is indicated for surgery to elbow, forearm and hand surgery. Okay, and the tentative position basically short axis to the arm and distal to pectoralis major incision, and I will aim to provide the local anesthetic spread around the artery and with a volume of 15 to 20 mils. So it is quite a simple block to perform. Okay, and it is lower risk compared to interscalene and supraclavicular block, and you are not absolutely necessary to identify individual nerves. So the position of local anesthetic around the vessel axillary artery is sufficient. So, if necessary, medial skin of upper arm intercostal brachial nerve can be blocked with injection, and then we will cover this intercostal brachial block during tomorrow hands-on session. Okay. So basically, this is equipment I think everyone familiar with. Okay, we need ultrasound machine with linear transducer with a high frequency probe, 12 to 15 megahertz. Okay, stripe cover, standard nerve block tray, disinfectant, syringes with local anesthetics, 5 cm will do, mainly not for our patients. Peripheral nerve stimulator you plan for dual guidance, and also opening or ejection pressure if available, and also strike gloves. Okay, so basically this is our structure of interest. Okay, you see that this is the axillary artery. Okay, there's the conjoint tendon of the latissimus dorsi and also teres major here, and then you see numerous axillary veins, and then the lateral aspect, you will see the median nerve, okay, ulnar nerves, the medial part, and also the posterior to the artery is radial nerves, and this is biceps brachii and coracobrachialis, and you see the musculocutaneous nerve in the investing fascia that lies between the biceps and coracobrachialis. This is also another similar diagrams. Okay. Okay, the indications mainly for anesthesia or anesthesia of the upper limbs from just above the elbow to the hand, and somehow suprascapular nerve not covered. If you need it for shoulder joint, you need to do it separately. And also intercostal brachial nerve, especially surgery in both medial upper arm. The position, okay, ergonomicity is very important when you do the any type of blocks. Okay, you can the position ideally you need to abduct the shoulder to expose the axilla. Okay, not to hyper abduct the shoulder, and then to externally rotate the forearm, and a line of sight of the probe whether it can be at the head. So basically, you're along the patients. Okay. So the ultrasound is here, this is the operator, or on side of the patient across. That means you're standing here, your ultrasound will be in the opposite. Okay, you can do either a long or a cross technique. Okay, so some mistakes sometimes are usually made. For example, probe is too low, so you can't really see the ideal structures. The place probe up against the pectoral fold and try to go as proximal as possible. Okay. Okay, this is the artery, conjoint tendon, again, coracobrachialis, and bicep brachii. And this radial nerve always superficial to the conjoint tendon and is larger than other nerves. And median nerve always adjacent to coracobrachial, which is lateral aspect, and also ulnar nerve, always medial to median nerve. Okay, the first case is Mr. M.A., 23 years old, okay, body weight of 60 kilo, day 10 post-MVA, sustained right upper limb injury, closed fracture, middle shaft radius, and base right metacarpal. Okay, the procedure I planned was right axillary with musculocutaneous nerve blocks, total volume 30 ml, 0.5% of pivacaine was given in this case. Okay, so I'm doing the cross technique, standing opposite the ultrasound, but on its lateral side. Okay. Okay. So you can see the needle approaching from lateral aspect of the probes. Okay. So I'm aiming at the, this is a perivascular technique, so I'm aiming at the posterior part of artery. Okay. Okay, I'm injecting around 10 mL of local anesthetic there. You will see the hydro dissections, the hydro dissection, and then the pull of local anesthetics. And then I proceed with the ulnar nerves. Okay, preferably to block the area posterior to artery. Okay, so we block the radial nerve first. So this will make the other structures more superficial when you block posterior to the artery. And then I follow, with the injection of local anesthetic to anterior part of the artery. Okay, you see there's a local anesthetics pool surrounding the axillary artery, and then now we are blocking the musculocutaneous nerve. So sometimes after injection you can get a clearer vision. The term is getting more visible. The nerve. Okay, so in this case, we follow up the patient, duration of sensory deficit 10 hours, and duration of motor block 8 hours. Okay, So simplest approach is a in-plane perivascular injection technique. Okay, you must ensure that the conjoint tendon visible here. Okay, visible. Any advanced needles to posterior aspect of artery, and then followed by anterior aspect. Okay, and after that you proceed with the invitation around the fascia of NCN around 5 mils. Okay, another method you can do this in plane perineural injection technique, but in certain patients maybe there's a bit difficult to see the individual nerves, but you can try to find, but don't waste time. So I think the perivascular technique also can be done, and then basically the success rate is quite similar. So you need to identify each of the 4 main terminal nerves, okay, and you need to enter and inject into the individual nerves. Okay, again we start with radial nerve, then followed by ulnar nerve and median nerve. Okay, this is another video. Okay, this is a perineural technique. So I'm aiming to radial nerve. In this patient, pediatric patient, 10 years old, 24 kilo boy with close fracture distal end radius for CMR and NK widening. And this patient, for information, has been anesthetized. So basically, I'm using a lower concentration, 0.2% ropivacaine. Okay. Okay, so you can see the radial nerve here. And then this is the ulnar nerve. Okay, now we're infiltrating around that. 4 mils here and 4 mils around the ulnar nerves. Okay, every injection is a test dose. So basically we need to aspirate and gradually and slowly inject the liquids of the local anesthetic and maintain the pressure to occlude the numerous axillary veins. And then we proceed with the median nerves. 4 mils, 4 mils, and 4 mils each. So total 12 mils. Okay. And you see the median nerve getting more, the visibility improves with the injections. The perineural injection. And then finally, we proceed with the musculocutaneous nerve injection. So total 15 mils, 15 mils, 0.2% ropivacaine administered for these patients. Okay. This is some tips for the in-plane perineural techniques. So we hydrodissect the artery, and then we locate the radial nerve, and we give perineural implantations, and then followed by the median nerves, and also ulnar nerve, and then last but not least, musculocutaneous nerve. Okay, another method you can do out of plane axillary block is only you need to do single skin puncture, but can always use. It's preferred for handling and shorter peritoneum and less painful for patient. But I think the in-plane axillary block more preferred. So because advantage you can keep and monitor the needle tracking. The limitation with this outplane is needle tip localization requires experience and expertise, and very difficult if shoulder is not abducted and fully external rotated. Okay, this is some study that compare between perivascular and perineural ultrasound guided technique for 60 patients. So basically they're comparing between the perivascular versus perineural. So you see in terms of onset, there's almost equivalent, and also onset of sensory and onset of motor blocks. And this is a total duration of sensory and perineural, perivascular. From this study, the difference between the perivascular and perineural statistically was not significant. Okay. This is out of plane. Samples. Don't worry about vascular puncture if you plan for perivascular or perineural, because if you see the visible port expansion, unlikely you are in the intravascular. Okay, you are more worried about neural puncture. In order to minimize direct nerve injury, the block needle should come obliquely or tangential approach to the nerves or artery. Okay, nerve and vessel should roll as the needle pass under over them, and beware of axillary and septa, and you can feel the pop when you pierce the tip. So some tips: it is frequent to aspirate with slow administration of local anesthetics, so this helps to reduce intravascular injection. So if no spread seen on ultrasound image despite the injection, the tip of needles may be located in the vein, and you should reposition your needle tips. Injection should be stopped immediately, and needle will be withdrawn slightly. Let's say we can't see the local, the area of where the local anesthetic deposited. And pressure on transducer should be eased before reassessing the ultrasound image for presence of vascular structures. And anatomic variations of MCN can be varies, and with catheter insertion to insert in longitudinal place alongside the artery, which may need greater degree of skills. So somehow there's a few contraindication to axillary block. Again, for example, patient on coagulopathy, okay, and there's a risk of hematoma. Okay, so I think with that, I thank you for your attention.